We welcome you all to Talk the Talk. My name is Janine Stiene,
And I'm Toni-Ann Antoniato.
the Masters of Myofunctional Therapy.
Together, we interview physicians, dentists, and other professionals to learn how their expertise can benefit you, your child, or your patient's speech and language skills and complement the services they are receiving. On this episode of Talk the Talk, we welcome Dr. Jafari, who is a dentist specializing in airway health and the founder of the practice Integrated Family Dentistry. Dr. Jafari continued her education past her doctorate degree in airway dentistry and mouth-body connection. Dr. Jafari recently welcomed her third child into the world and quickly recognized that her baby had tongue tie, lip tie, and buccal ties, which were impacting her ability to breastfeed and have proper oral rest posture. Dr. Jafari is joining us today to share both her personal and professional experience in the area of tethered oral tissues. Thank you, Dr. Jafari, for joining us on today's episode.
Thank you all so much for having me. This is going to be fun.
Absolutely. You shared a lot of your story with your followers and social media followers. And we were one of those to hear that story. And we thought that it would be wonderful to have you share with our audience the experience that you went through.
Absolutely. I think the whole reason why I documented it was because of all the stories that I hear from my patients and the struggles that they go through. So I wanted to just bring light to some of the challenges that you experience as a mom and aren't really listened to because I had the same situation with my older daughter. I was sure it was going to be a similar situation. So I wanted to document it to bring more light to what's happening at the hospital and after birth. So I'm happy. I'm hoping that it will help some moms and also hopefully bring some awareness to some of the challenges that tongue-tied moms go through.
Agreed. I even think it's wonderful for other professionals to hear your journey as well, because sometimes it's so hard to be the professional knowing a certain area and then also advocating for your own child. Like it's there's a fine line there. So it's wonderful.
Absolutely.
That you do that.
Mm-hmm.
Absolutely.
Yeah. So you had, before we go into everything related to those tethered oral tissues, you had documented in the first 48 hours of your daughter's birth that you did some checks on infant reflexes that your infant and child should present with following birth. Can you explain to us what you were looking for and how you looked for that and why it was important?
Absolutely. And great question. Before I start going into that, I do want to put a disclaimer out there. I'm in no way an expert when it comes to oral function or reflexes. Everything that I have learned along the way over the past 10 years I've been doing this has been just working with amazing providers who I've had the pleasure of collaborating with and learn things along the way. And I feel like as a provider who performs this procedure, it's my responsibility to know a little bit on that aspect of things and be able to check for some of these reflexes to make sure after I'm doing this, this procedure, if the baby is going to have a positive outcome or not. And I feel like these reflexes are a great starting point to some of the things to check for, because as you guys know, we're born with some of these reflexes. They're meant to stay for a period of time and help us develop proper function for whatever that muscle group is. And then they're supposed to leave after a period of time. And then our muscle memory takes over at that point. So for example, two really cool reflexes that get activated during birth, the ATNR reflex and the Ferguson reflex are activated to help us navigate our way out of the birth canal. And I thought that's like super cool. So those reflexes, obviously, like an occupational therapist checks for, especially for babies that went through a C-section birth, like helping react or activate that. So to help with, those muscle groups. But the reflexes that I check for, and I routinely check for them on every infant that comes to my office to get a procedure done or get evaluated, are more related to oral function. So I check for the tongue lateralization reflex, rubbing an infant's gum from the middle to the side. You should see the baby's tip of tongue move with your finger to the side that you're going to. Then there is the phasic biting reflex that I check for, which is putting pressure on the back of back gums on the upper gums. The baby should be chomping, and you should go to the other side. You should see similar chomping and more repeated chomping on your finger. Then there's the rooting reflex. So touching the corners of the mouth, the baby should turn their head to the side that you're stimulating. The tongue thrust reflex, checking or touching the lower gum line. The baby should be bringing their tongue forward in a thrust motion that helps them or be able to latch with their tongue to the breast or bottle. The other one, the gaping reflex, which is a really cool one. I actually learned that from an amazing lactation consultant in the Atlanta area. Her name is Avery Young. And she actually was able to see that in her patients. Like every time she stimulated this area, on babies that thrived well after a tongue tie release, they would open really wide. But other babies that don't have this activated, they have a more guarded opening of their jaw, and or even don't even like open to latch. So that one I think is one that I consistently see with babies that I treat if they don't have that reflex active or if it's guarded. So if I stimulate that and they just open small, then that trend also continues after the release. They're not opening wide for a latch. The other big reflex is the suck reflex. With the suck reflex, obviously that's there to help us like be able to feed after we're born. And in some babies it's not active at all. And in those patients, I feel like those patients are some of the ones that as soon as I see them, if they don't have that reflex, no matter what age they are, what situation they are, it would be I say that the age thing, it's actually only active in the first 2 to 3 months of life. So if they are super young and they don't have that reflex, then it's best to get that stimulated before doing any type of tongue tie release procedure, because if they don't have that reflex to rely back on after the tongue tie release, and we've just gone in there, released the tongue, everything feels super different in their mouth. They don't have anything to rely on afterwards, and they may not have successful feedings. So that's a big one. But with the suck reflex, there's a lot of different things that you can check for. You can look to see, so using your pinky or your index finger, you evaluate to see if they are able to suck your finger in. So you just kind of like hold your finger right in at the tip on their lip and see if they are able to latch onto that. Is their tongue cupping, curling around your finger to be able to maintain that latch? is the tongue coming forward to maintain that latch? Do you feel pressure on the tip of your finger from the back of the tongue as they're sucking? There's so many different things that you can look for, like, do they suck for a little bit and then they stop and rest? Do they maintain the latch with their jaw instead of their tongue? There's so many different things that you can check for with that suck reflex, and I think that's one of the most important ones when it comes to infant releases. So those are some of the things that I checked for in my infant. Obviously, like I think it was like the second day that she was born, to see how all of those are active. And fortunately for us, most of those were active. But in a case where it's not active in an infant that I check for, that's an immediate a referral to a speech therapist, occupational therapist, and that works with infants to help, or a lactation consultant to help develop those.
Dr. Jafari, in your experience, is there anyone else, and now again, knowing your background or even working with a ICLBC, do you see that those reflexes are checked regularly, whether it be by the pediatrician or the hospital staff immediately following birth, and or even just on some of those follow-ups, those regular follow-ups that you see during that first year of life with regards to infants?
So pediatricians check for a few more body reflexes, like the Maro reflex and the stepping reflex, and some other ones on routine basis. Oral reflexes, I'm not sure if they're, readily checked for. I think when it comes to I think lactation consultants have a lot more knowledge when it comes to infant feeding, especially if they're IBCLCs. And I've had several lactation consultants that check for some of these reflexes, especially like the sucking reflex and things like that. So I feel like when it comes to infant feeding, IBCLCs obviously are the experts in that. And then I definitely work with some amazing speech therapists and occupational therapists that also specialize in infant feeding, and check for these. But I don't think it's something that's like, there's a lot of reflexes. So like, which ones would a pediatrician check for, unless the mom is struggling.
Absolutely. What are some of the symptoms that you saw in your daughter that were related to her posterior tongue tie, lip tie, buccal ties? What kinds of things were you seeing, or did you see?
Yes. So I am a mom of 3 tongue-tied babies. So I kind of like expected, that my new one will also be tongue-tied. So the main symptom for us, so she had a few symptoms where her upper lip was curling under, and she wasn't able to flange really well. We struggled with weight gain with Leva. So initially, like the pediatrician, we had a big drop in weight when we left the hospital. Pediatrician was worried and wanted us to come back. So in the first week, she was dropping in weight. She wasn't able to gain weight.
Okay.
Along in the same with the same symptom of her not gaining weight, I also had symptoms with my breasts. I had a clogged duct that in the first week on one side. So I know she wasn't able to empty really well. So even though her suck, looking at it, her latch looked really good, which is why it was, I had several people check, but it was because the latch looked good from the outside. They weren't looking for anything further than that, I felt like. So even though it was excruciatingly exhaustingly painful for me, excruciatingly painful for me. A 10 out of 10 pain. Like when she was about to latch, it's like, okay, close your eyes and just put her on, and like, oh,
Yeah.
I
it's
have to
very,
feed
very
you again. I have to feed you again, right?
all the time.
Wow.
Because obviously, like if she wasn't able to get a lot of milk out or empty me out as much as she should have to be able to gain weight. She was also hungry a lot, so she was nursing a lot, and was just like extremely painful. So when I would have people check and they're like, "Well, it looks perfect," I'm like, "But it's still like very, very painful. My nipples are." This is like my third baby that I'm breastfeeding. My second one I breastfed for over 2 years. So it's not like it's my first rodeo. Like I know what I'm doing. I It's not like the first time my breasts are being used for feeding. So I'm like my skin's kind of used to it, my body's used to it, and it's still this painful. There must be something wrong. There must be, obviously, like I knew the answer, but
Let's see if you
but I was being, discredited or like not even like listened to, because they're like, no, well, everything looks fine. So, and they would say, oh, you'll just get used to it, just take a couple of days and then you'll get used to it. Which didn't happen for us. So like a week later, I was still in excruciating pain nursing her. So
Absolutely.
I think that was like the main ones. I mean, obviously that's a lot, but
It takes us into our question surrounding, what that was like in the hospital when you had those routine check-ins and you were expressing your concerns and they were evaluating and saying there was definitely no tongue tie, no restrictions. And you as the mother
yes.
also having that experience, how was that for you in the hospital? Just having had birthed a child, you're in pain, and they're telling you that there's no tongue tie, lip tie, buckle ties.
Yes, so I stayed quiet. I wanted to make sure to go in as, as a mom that doesn't know anything, and wanted to see what kind of support I would get. So obviously I had done an evaluation. I knew what was there. My daughter's tongue tie was an Eiffel Tower tongue tie, which is a tongue connection with a really wide base to the lower jaw, which looks like an Eiffel Tower. These tongue ties go undiagnosed. The most undiagnosed tongue tie that I see in my patient population, because it looks like the tongue is moving, but in order for the tongue to lift and move, it pulls up the entire floor of the mouth. And with that big compensation from pulling that tissue off the lower jaw to be able to function. So it looks like the tongue is moving, but with a lot of compensation, which most providers are not trained to check for. So I had one of my nurses was a lactation specialist. Then I had a lactation consultant, and then the pediatricians that would come for checks. I think I may have even asked the OB, but I had everyone. I asked everyone about the pain. Um, um, a couple of the providers just deferred to the lactation consultant. They were like, they'll just check. They didn't even check. But the ones that did check, and I waited 2 days for lactation consultants and the lactation department to come by. And when they came, she did an assessment, and it was literally just holding Levi like this. And as she cried, she just looked in her mouth, like just looking. I think she may have just like put her fingers inside the mouth, but like that was the extent of it. There was no actual like lifting the lip, lifting the tongue to see if there is something there. And she just said there's no obvious lip or tongue tie. And I agree with her. The tongue tie was a submucosal. It's not obvious. You have to lift to see. But her lip tie was a grade 4, meaning that it was connected all the way to the roof of her mouth. So that was definitely obvious, in my opinion. But regardless, it was just not a very thorough examination. She did evaluate our latch, which she said it looked great, but there wasn't much attention paid to the symptoms. And I think that's, if you're looking at tongue ties, you have to be looking at a multifactorial, multi-faceted approach to tongue ties, and I didn't feel like we had that.
I think that's so common that when you look at the latch, it looks normal there. And for our patients, a lot of them are gaining weight or will gain weight, but so the parent thinks everything's good, only know that they've utilized all these compensatory strategies that are now affecting them 5, 6, 7, 10 years later. And the mom's like, all right, I did the best thing. I breastfed. I did what I was supposed to do. She shouldn't have a tongue tie. She shouldn't have a tongue thrust. And then we're like, oh no, she does. And they're like blown away, So I do think that is really important. What you're saying is that sometimes it's not assessed deep enough or into it enough to really understand what the tongue is doing. And it's not just the act of latching or the act of gaining weight. A lot of it is there's so many other pieces.
Yes, I think there's a lot of weight placed on gaining weight for infants. And I feel like if a baby's gaining weight, a lot of things are, just dismissed. And typically, like I see two sets of the two aspects for when it comes to mom symptoms. It's either that the mom is in pain, they're having a lot of discomfort and with their nipples because the baby's like really strong and is trying to get milk. So they have symptoms on their end. But there are also babies that are very dysfunctional, but the mom has like no symptoms. The baby is gaining weight just fine. And you're like, how is this possible? And I have gathered that most of my patients that are not having a lot of symptoms, babies like super dysfunctional with like really tethered tissues, is when the mom has really good supply. The baby just needs to like just get on the breast and just sit there and swallow. They don't really need to work at the breast. So mom has no symptoms and the baby is just gaining a lot of weight because they're just sitting there swallowing the milk. So there's definitely like so many different aspects when it to tongue ties and being able to diagnose and treat and especially for the diagnosis. And I feel like pediatricians have a huge role here, and I feel like they should be more involved in learning more about tongue ties and being able to help moms navigate. So especially if they're first-time moms, because I get second, third-time moms come to the office and they're like, like this is not normal. Like I breastfed 2 other babies. This is not normal. My pediatrician says it's normal, but I want you to check because I don't believe my pediatrician. But if it's a first-time mom, they just don't know better and they feel like that's the way it's supposed to be. And we should be able to rely on providers too that are experts in the field to help us navigate motherhood.
How do you handle that? How did you handle when something's wrong, but a provider, somebody's telling you something different? Do you immediately refute it? Do you get another opinion, especially with your background knowledge?
So I definitely get second opinions. I look for experts in the field. I ask for referrals from other providers that I trust. A lot of times what I have learned over the years with my babies is that you really have to advocate. You need to educate yourself and be able to advocate for your own kids. I feel like that's where how the field is going to grow as well. And the more the parents are knowledgeable, the more they go into their providers asking for these things. I think it brings more awareness with what's going out there and what parents are struggling with.
Absolutely. What are some of those main symptoms that a parent or a provider even could look for when it is not that anterior tie? We know that a lot of the times a pediatrician can very quickly identify and refer for that anterior tip of tongue type of tongue tie. But when, like for your daughter, is that more posterior, less obvious? Symptoms should always rule the game when it comes to ties anyway. So what are some of those just main symptoms that our listeners can kind of know? If you see this, this, and this, that could be an indication that there is some type of posterior tie.
Yes. So for posterior tongue ties, we're looking, one of the main ones is tongue rest position. So typically, even a baby is tongue tied and they're born, they typically have a high resting tongue position. And over the months, it changes to where the tongue is resting low. But that's one of the main things to look for. Is the tongue resting low in the mouth, or is it resting up on the roof of the mouth where it should be resting? If one of two things can cause a low resting tongue posture, one is a tongue tie, the other one is a more habitual, like if a pacifier is in the mouth all the time, the tongue learns to rest low. But if that's not the case, then it could be a tongue tie pulling the tongue down to the floor of the mouth. The other one would be a white coating on the tongue, and we typically see it for posterior tongue tie on the further back of the tongue. Is sometimes misdiagnosed as thrush, which could present with a similar look. But a lot of times it's just milk residue that sits on the tongue and in between the tongue cilia, and it's not able to get clean by the roof of the mouth where it's supposed to rest. And when we swallow, the tongue has a self-cleaning action with the roof of our mouth. And if your tongue's not resting up there, or if only the front is resting and the back is not lifting up, the milk kind of tends to sit on the back portion of the tongue. Also, if a baby's crying, you can look to see how the tongue reacts. Is the tongue lifting up? Is the tip lifting up? Is it curling into a cup? Is it just the sides lifting up and the tip is down? So just looking to see how the tongue also moves during crying. With the lip, there's also things you can look for if during a feeding, if the lip is not able to flange over the nose or lift up, if it's curling under, that could be an indication that there is a tether or a tissue underneath pulling it in. If there are lip blisters around the lip, so if they're little, it looks like they're double lipped. And they're like little blisters all around. Parents say, yeah, it just dries, falls off, and then they get the blister again. And that's just overactivation of the lip during feeding. So that's something to look for. Another one is called tinted lips, so lips that stay open. And they actually kind of looks like a tent. So called a tinted lip. It just indicates if there's like tension underneath the tip, it holds the tip of the lip up. So those are some of the like quick things to look at and see if those are problems that may indicate a lip or a tongue tie and would be good to send for an evaluation.
9 days of age was your daughter's release day, and you performed that release and documented an emotional moment. How was this day for you, specialist and as a mom?
Yes, so it's interesting because we had I obviously wanted to like document the whole release and all of that. And I was struggling with postpartum depression as well. And I knew it was going to be an emotion. Like I was just like really stressed and nervous about the whole procedure. Even though it's something that I've done for years, and it's so different treating your own kids than, treating a patient, having to wear both shoes. I wanted the surgery documented, and it was my husband recording. And when I got emotional, he continued the video, and afterwards I was upset. I was like, you did not have to catch that. And it's just like a vulnerable place to be. So when it was time for us to put it on social media, I wanted to cut all of that out. But then I thought about all the moms that come to my office, and they get very emotional over the whole process. A lot of them cry, just the thought of like having to have the procedure done. A lot of them feel uncomfortable about the fact that they're crying. Most of them are struggling with postpartum depression. And I just felt like it was really important for parents to see that everybody goes through that, even one that does this all the time as a living. So I did decide to put it up, and I've had like a lot of parents that thank me for that, and saying that it made them realize that it's, everybody goes through it, and it's struggle even for me doing it on my own daughter. So as we were doing the procedure, obviously I was like focused. I had my provider hat on. And as soon as that last release was done, it was just like this whole like it was like a bucket of cold water on my body, and everything just kind of like relaxed. And then it was like my mom had on, and I had to just like take a moment, and then had like picked her up, kissed her all over, nursed her, and like we were able to reconnect. But it was a very emotional journey. It lingered for a few days after. It was just emotional draining. So typically when I do tongue tie releases, I do it with me and my assistants. I don't allow parents to come in the room. And it's been it's been great to be able to tell parents, I'm like, you know what, you don't want that emotional burden. Let me take care of it. I'll bring her right back to you, and you can feed her and love her and be there for them emotionally to be able to support them. It's been an interesting journey.
It was a beautiful video to watch. When I watched it, I got
Thanks.
emotional and teary. Hearing you now, I could tell. Oh gosh.
Exactly. I'm like, take a deep breath, my lip starts to quiver. You know why?
But it really was a nice moment, and it was.
Thank you for saying that.
If we rewind a little bit before you actually did that release on day 9, you waited because you were looking for certain things to show that your baby had that readiness to have the procedure. Can you tell us a little bit about what you did in those 9 days?
Yes. To be honest with you, when we were driving home from the hospital, I was like, maybe we should go get it done, because it was, it's so easy, because it's right there. I could just take her over there and do the release. But I wanted to be patient with the process. I know that a baby that's been in the womb for 9 months, they present with some tension patterns, like they have been in this ball for 9 months. So it's good to allow the body to just kind of unwind from the womb. A big part of that is body therapy, working on releasing tension in the body. I have an amazing colleague, Karen Woods, who's a phenomenal occupational therapist in the Atlanta area. and we've been working together for a few years. I had told her, before that I would want her hands on Leva as soon as she was born. So on, I think it was the first or second day we came home from the hospital, that she actually came to the house and evaluated Leva, worked on her body a little bit. I did have a craniosacral therapy appointment scheduled from a month before the due date, to make sure that I was able to get into this Leah Mahadeo, who's an amazing lactation, an amazing CST. But unfortunately, she got sick that week, so we weren't able to see her before the release. But we did also work with a chiropractor to help look for those tension patterns. Karen also helped me with some functional exercises. She did a more thorough evaluation of all Leva's reflexes, birth reflexes throughout the body and in the mouth. There were some exercises that she had us working on before we did the release. So I feel like it's important to, obviously, like some babies that are tied to the tip and are not able to feed at all, that's a different story. But if you're able to wait a little bit and do some of these body work on the body, work on oral function, that you see better improvements post surgery.
As a provider, do you often see individuals or patients that had their freedom, their tongue tie released during infancy, but yet it needs to be re-released, or a revision procedure is necessary?
I actually see a lot, and
Okay.
obviously my practice is it's geared towards airway and tongue ties. We are a full general dentistry practice. I'm a general dentist. We still do fillings and we do your cleanings, but the majority of the practice is focused around airway. We do a lot of growth and development, expansion, and things like that on kids. We do orthotropics and just arch development. So I do get a lot of patients that are tongue-tied or had tongue-tied releases as infants, but still are struggling with some functional challenges. Some of them do need to be have revisions or functional frenuloplasty. So they had a frenectomy as an infant, but I also specialize in functional frenuloplasty, which is Dr. Zaghi's technique from the Breathe Institute. So for the kids and adults, we have a more functional, thorough approach. The frenectomy as an infant, it's to take care of most of the symptoms for feeding. So it's a quick release. It takes seconds to do the release, and then we rely on wound management stretches to prevent things from reattaching. So there are different exercises that help with that, but sometimes there is reattachment, or whether it's the way the baby healed, or if the initial release wasn't done properly, or deep, or it wasn't a complete release, or there is more of a posterior component that is more involved in that muscle that we typically don't release in an infant. So once a baby is tongue-tied, they have to be evaluated through the years. So a lot of parents ask me, okay, so I just wanna, I see the tongue tie, but I wanna get it done to make sure they never have speech issues down the line. And it's a difficult conversation to have, to say, this is not a guarantee one way or another. Like, you can't release an infant and expect they'll never have speech issues, sleeping issues, or any other issues down the line. What I say is, let's concentrate on the symptoms that are happening now. Let's try to control this reflux or colic symptoms or whatever the symptoms are coming in for. That's their main concern, or their feeding issues. Let's try to improve things now, and just know in the back of your mind that hopefully this release will help get some of that restriction out of the way so that they have better function down the line, especially working with a functional provider to make sure that our oral function is perfect. We'll get them to be able to transition better to solid foods. We'll be able to have less that they have to make speech a little bit easier to develop, but doesn't necessarily mean that you did a release today and they will never have those issues down the line, or vice versa. I have seen patients that are older that are coming to me for other things, never had speech issues, and they have severe tongue ties. So it's, you know, it's a interesting multi symptom problem that doesn't present the same way in every patient. So it's interesting.
Yeah.
We explain that often too. You know, it's so individualized. You could have a tongue,
Yes,
you can have a tongue tie, and you could present totally different. Everyone's
absolutely.
and so are their symptoms.
I just
Yes.
recently had my tongue released,
Yeah.
and now I can say without certainty when I talk to patients, hey, this is what it feels like. This is what it entails. And you have to do
That's
your
amazing.
Mhm.
That's amazing. Yes.
It made a huge difference. I could feel that release just in my entire
Wow.
body as soon as
I love it.
it was amazing. It was amazing.
That's so great. That's so great. And it's because you probably did all your thing. Obviously, it's, you know, it's something you do on a daily basis with your exercises. So that's such a huge part of this whole thing. And what you guys do is so important with kids and adults and infants working on oral function. What I explain to parents is like, um, it's kind of like having your shoelaces tied. You could be wanting to walk, but you have a small step. If you were to, you know, at, you know, 7, 10, whatever, 15, 20 years of age, someone was like, oh my gosh, your shoelaces are tied, and they just came and opened them, you're still gonna walk the same way because
Right.
that's your muscle memory. So unless you reactivate those muscle groups that have not been working all these years or all this time, you still stay in the same functional pattern. You still have the same symptoms, but if you address it from both aspects, then you tend to have more success from the release.
All pieces to the puzzle.
Yes,
Mhm.
exactly. And that's when it comes also with like assessing oral ties. It's even in an infant, it's multifactorial. So you have to look for a functional, you have to do a functional assessment, meaning that you're looking at those reflexes and the function to see what the tongue's actually doing. You have to look at the structure. So you have to do a structural assessment, meaning that you're actually lifting and looking at those structures. You have to also look at symptoms. So sometimes it doesn't present like a tongue tie, but the symptoms are there. So you have to look at those symptoms, or they have a tongue what looks like a tongue tie, but baby's functioning fine. Like, you do a release at that point. Another big aspect of it, in my opinion, is also the emotional status of the family. One thing that I tell parents is that the tongue tie release, and what I do is like a small portion of the whole aspect of a tongue tie release. And the most important and most challenging part of the tongue tie release in an infant is those post-op stretches and being able to do those to prevent reattachment. And if the parents are not there for that, if they're not ready to take that task on, it may not be the best timing, no matter what you think would, you know, if you feel like the baby definitely needs it. If parents are not there to do those, it can reattach worse than initial with, so it's like the reattachment and then the scar tissue on top of that. So you also, I feel like it's important to gauge the emotional status of the family and the parents to see if they're up for that post-op care.
Definitely. Absolutely.
I would say Toni-Ann and I would both agree that there's definitely more of a focus in the last 5 to 7 years on tongue tie, the importance of proper resting posture, the purpose of having an open airway.
Mhm.
Do you see that change since you started your career till present? And do you feel like we're just going to move forward from here?
Absolutely. I feel like I'm so with you on that. So so I started doing things with airways, slowly getting into all of it in 2014, 2013, 2014. And initially, and I would say the first 5 years, it was just me and one myofunctional therapist, Beth Sohail, who is fantastic. And so we were the only ones in Georgia. Or in the Atlanta area. But I feel like in the past 5 years, when it comes to airway, it's just blown up, which is so amazing. More providers are interested in getting into treating airway or function for betterment of the airway. More parents are looking for answers, and I feel like there's also a lot more moms that want to go back to breastfeeding, and they want to go back to more natural way of doing things. So I definitely think this is like the best time to be in, most exciting time to be in the field, because so many people are coming around to the idea, and I would hope that it's going to continue in the same trend.
Could only hope so.
Yes.
Yes.
Following the first few days, if we could talk about what you noticed in your daughter the first few days after the release, and then we can go into maybe the first few weeks after release and what those days and weeks looked like.
Yes. So for us, immediately after, there was a lot less pain with nursing. And it's not, I see it a lot, but it's not every baby that has that immediate relief in pain. Thank goodness for us, we did have that, because everything else was working. So, the latch looked perfect. It was just the tongue not functioning really well. There was a lot of like jaw movement with the Eiffel Tower. There was a lot of chomping. So there was a lot of improvement with nursing. She started gaining weight. I actually, I haven't been able to stop her from gaining weight. She's 9 months and 18-month glow. She's a big baby.
Wow.
Yeah, so she just flew off the charts with her weight gain and just body growth as a whole. And no more clogged ducts. Supply came in and was really strong. So everything with breastfeeding improved for us. I do want to mention we continued working with our providers. We added on more providers along the way. Karen Woods, the occupational therapist, helped us on several occasions. We went back and worked through some different challenges we had. I worked with Nicole Shores, who's another amazing IBCLC, with pumping when I started working again, because I mean, this is my third time pumping at work, but like, you need help if you need support. And I always thought pumping was supposed to be uncomfortable. So she helped me with finding the right flange size and how often I should be pumping to maintain my supply. and things like that. We saw craniosacral therapist, Leah Mahadel, a few times. We worked with Mikhail Fleming, who is a CFT, craniosacral fascial therapist, and an IBCLC on a few sessions. Continued seeing the chiropractor. So there was a lot of body therapies and different types of therapies that we tried. Just because obviously I know these providers, I'm in the field. There were I had to use them because I know they're amazing with our dyad. But so over that took weeks and months, but it's been positive changes as we've gone along. The one thing that lingered for us for a long time was her open mouth. So she would keep her mouth open. And on a few occasions, like I could tell she would close her mouth, but then open to breathe. So I knew there was something else going on. That was obviously everything was healing fine. Everything was looking fine. When she was resting, her tongue was up, but as soon as she would start moving around, she would open her mouth to breathe. And then we found out that there was a dairy sensitivity. So we cut out dairy, and all that inflammation went down. She is able to nose breathe and keep her mouth closed and all the things. So there's so many different aspects to it. I think diet is like a huge one also, that needs to be considered when it comes to the success of a baby thriving from tongue-tied release or just in general.
Do you feel that you were able to advocate for all of the support with the different professionals because of your background? Or do you feel that you were getting those recommendations along the way? Especially for the parents that listen, to know, okay, if I don't have the background knowledge of a doctor, how do I know to enlist the support of all of those different people?
Great question. I feel like as moms, we just have that natural instinct. Like a lot of times we know that there's something wrong and we are being told otherwise by providers. I feel like that's the biggest thing we have going for us, is that mother instinct. I would say just listen to your instinct and do your own research. So if you know something, if something doesn't feel right, there's probably something going on. And I think doing some research and looking for people that are experts in that field to go in for second opinion, third opinions, and see what other providers say, rather than just listening to one person, because they may not have had that exposure. Like most dentists, like we don't learn anything about tongue ties in dental school, right? In speech, in your programs, you guys also are in the same boat as us.
Yep.
Just don't, it's all what you're exposed to after you graduate, and if your life brings you to those treatments, that you learn more about it. And I feel like there tend to be a lot of different resources out there that parents can utilize, but a lot of it unfortunately is up to you, and you're researching your own thing and bringing, looking for providers that will help support you in that.
Absolutely. So tell us a little bit more about Leva today. You've already mentioned she's 9 months and 18-month close. So would you say she's thriving and doing wonderful?
Yes, she's thriving. She is she started sleeping through the night when she was a month and a half old.
Wow.
I know, I'm
I'd have
so
another
spoiled.
child if that meant, if that was the case.
I know, she's the most easygoing, super sweet baby. We obviously learning a lot from occupational therapists and physical therapists that we've seen along the way. Eliminated a lot of carriers. So no no bouncies, no, just putting her on the ground and letting her develop her inner core muscles before that would help support her in the gross motor skills that she's developing. She is extremely strong. She has met all her milestones with rolling over both ways, crawling, and not just crawling, any crawling, but even crawling on both sides, not a janky crawl on one hand. And she's already like pulling up to stand. So she's really strong, but is also very flexible. So a lot of times you hear babies that are like really strong, but a lot of that is coming from tension. So she's definitely thriving. We're still breastfeeding successfully. Yeah, she's super sweet. I was gonna bring her over because I'm home, but I think she's down for a nap. I'll go check at the end and see if she's awake, and I'll bring her over.
That would be fantastic. I have one last question. I promise this is
Yes,
it.
no worries.
How do you compare your two older children that had tongue ties, their development compared to the youngest?
Well, my first child, who is 7, he is obviously like your definition of first time parents. Didn't know much at the time when I had Landon. He has a very posterior tongue tie, not an Eiffel Tower shape. It's all posterior. And even though we had challenges, we just kind of like made it through. That was before I was treating tongue ties at all. So we didn't know. He had all the things with all the swings and, the jumperoos and the walkers and all the things. So what I see with him and my second daughter, which we had her tongue tie was also released at 7 days old. She also developed naturally on the floor. There, even to this day, my first born is 7. My second one is 4 years old. My 4-year-old is a lot more stable with her posture and growth and development. She's a lot more developmentally. I don't know how to say this, but she's just a lot stronger in her core.
Right.
Where we're still struggling with my 7-year-old, even though we have him in different therapies, he still has a very strong core because we didn't do a lot of things, or we helped him compensate a lot along the way. My Leva I feel like is the strongest one of the 3.
Okay.
As far as what she's done with her growth and development, we have had the best nursing relationship. Even though I breastfed all the other ones, this has been the most comfortable and successful so far. So it's definitely, we're getting better, but I'm done, like not having any more babies. Even though we're more experienced, no, not gonna happen. We're finished.
3 is it. That was it. That was the max.
3 is it. Yeah, once you're outnumbered.
So
Whole
true.
new ball.
Yes.
Oh, thank you so much for sharing your story and putting it all out there, because obviously it's a personal one and it's something that not everyone would be also comfortable with sharing. And it's very obvious that your
Of course.
story touches many of the moms and other professionals out there.
Of course. Thank you so much for having me. I've really enjoyed it. And that was my goal. I really hope this brings some awareness and also helps parents or moms realize that everybody struggles with these things. So thank you.
You're welcome. We're going to play this in our waiting rooms, in our offices, just so parents can really be it's completely intrigued by the story and really such an educational experience as well. So
Awesome. I
hopefully
love that.
you'll change a lot of minds.
I love hearing that. Thank you.
You're welcome. You're welcome. Well, thank you so much for being with us today.
Of course.
And hopefully
Of
we'll
course.
get to meet in person someday.
Hopefully, I would love that. I'm gonna see if she's awake. If
Yes,
you guys
yeah.
want, I want to
I
go
would
see
love
real
it.
quick.
Yeah, I would love that. First of all, look at her little belly.
Thank you for joining us on this episode of Talk the Talk.
We hope it was enjoyable and educational and further supports you both personally and professionally.
For more information, please check out our Wyo Myo and Myo Minute podcast, as well as our other episodes of Talk the Talk. And don't forget to check out our tongue training appliance, Spot Pal, to help with tongue thrusting, thumb sucking, snoring, TMJ, mouth breathing, and so much more. Visit thespotpal.com.